Well, this is the Surgeon General's Pulmonary Embolism Symposium. And really what we've been trying to do, Dr. Galson, is to really set the stage for your talk, for your call to action. I would like to go back in time about 5 years when I first became involved with the Office of the Surgeon General. And a number of us as citizens, really, concerned health professionals and patients, approached the office and said, look, we think that pulmonary embolism deserves a call to action. And we were received very nicely and everything, but we were given a very long list of what we would have to do, because the Surgeon General at that time said to us, look, my office gets besieged daily with all sorts of illnesses and diseases, some of which none of us have ever heard of before. They're very rare. And you have to come back to us proving really that there's a groundswell of public support and public interest in this, number one. Number two, that this is a preventable disease. Number three, that we are not doing enough in the United States to actually apply the prevention tools that we have. So we had our assignment. We went back and worked hard, and the Office of the Surgeon General let us convene a 2-day workshop with your predecessor, and I want to acknowledge, first of all, one of our patients, Heidi Blondesteiner. Heidi, do you want to stand up for a minute? She opened the Surgeon General's workshop. Thank you, Heidi. And really from there, the Office of the Surgeon General, along with Dr. Betsy Nabel from the National Heart, Lung, and Blood Institute, who herself was an intern, resident, cardiology fellow here at Brigham and Women's, worked in concert to bring about this wonderful call to action. And I remember you, Dr. Galson, were appointed in October 2007, I think on October 1, and I placed a phone, I didn't know you at the time, I placed a phone call, I think on October 5 or October 7, just to discuss the whole issue with you, and you were very receptive and very proactive, and you explained the further steps that needed to be taken, and launched the call to action this past September, which we're also interested to hear about it from your perspective and really your emphasis on public health. You've been involved in prevention and in government service for more than 2 decades. You were at the FDA before you transferred to the Office of the Surgeon General. And I think that we both in ourselves to prevent further immobility, since we have been in a seated position for a while, and to express our appreciation for Rear Admiral Stephen Galson, should stand up and we'll give you a warm welcome.
Sam, and I'm really thrilled to be here, and it's fantastic to see this very full auditorium. I do want to tell you that I'm going to try to get through my prepared remarks fairly quickly and give you an opportunity to have an exchange with me and ask me questions. This may be your only opportunity to actually ask a question of the Surgeon General. So think of some good questions, and hopefully we can have a good discussion period at the end. I want to first start out by introducing a very special guest and embarrassing her I'm really pleased that my daughter, Sophie Wolf Galson, is here with me today. Sophie graduated from Washington University in St. Louis as an undergraduate last year. She's an emergency room tech over at one of your competitor hospitals, Bethesda Deaconess, and she's going to be going to medical school next year. I wouldn't really have the courage to serve the public as the Surgeon General without a very, very supportive family. And so it's particularly gives me a lot of pleasure to have someone from my immediate family here with me today. Thank you. As Acting Surgeon General, I don't know how many of you are familiar with the position, but I serve as this nation's chief health educator. I endeavor to bring the best scientific information to bear on how to give advice to Americans to improve their health and reduce their risk of illness and injury. And as I travel around the United States, I share information and advances in medicine and public health with people in all different walks of life. But I'm particularly pleased to be with this group today because a subset of you has already done a great deal to help me in one of my key educational goals, which is to improve provider awareness and to enhance DVT and PE prevention and care. So it's really special for me to be here. You heard a little bit about the history of this issue with my office. We know that millions of Americans are healthier today or will be in the future because of the work that's being done centered out of this group. So I'm very, very appreciative. The North American Thrombosis Forum, Dr. Goldhaber's team here have devoted a lot of time and effort historically to this problem. And until recently in this country, these two conditions have received really far too little attention. But I've seen that change. I've seen that change even over the last few years. We've seen important improvements in healthcare provider understanding of these conditions. And we're seeing an increased consciousness about the risks and consequences of these conditions as well among patients. And I'm great to see a patient representative here, and it's been very interesting to work with the patient community around helping patients to understand these risks as well. The Department of Health and Human Services, where I'm based in Washington, is honored to count the North American Thrombosis Forum and this hospital team as among our most valuable partners. This particular institution and your history of clinical innovation and discovery around DVT and PE is very, very impressive, and I wish I had been here all afternoon to hear a little bit about that history. Your leaders, Dr. Sasahara, Libby, Rabicki, and Cohn, I really commend you for your progress, your publications, and your outspokenness around this. This symposium really provides a unique opportunity, first, to continue to advance the clinical understanding of DVT and PE, second, to identify and apply the best ways, and to talk about how you all can be involved in applying the best ways to prevent. And I'm really pleased that in the short time I've been here, I've heard that prevention used a lot. And then to look at the future, an ultimate future where we have established the ability to prevent these conditions altogether. I know some of you may already be familiar with the Office of the Surgeon General and what the position of this role is, and hopefully it's not because of your personal experience reading cigarette package labels or reading the Surgeon General warning on alcohol products. But with the political transition in Washington, there's been a lot of news recently about the role of the Surgeon General in the United States, so I just want to spend a minute talking about that. The Surgeon General is really responsible in this country for helping to create and promote a culture of health and wellness, to emphasize the importance of disease prevention, to encourage our population to make healthy decisions for themselves, and also to promote policy changes at the federal government level, at the state level, and at the local level in this country so that we can evolve towards better health for all Americans. Today, as you know, we spend the vast proportion of our health care dollars on preventable diseases. Consistently investing in preventing chronic diseases is going to save precious lives, but it's also going to save us money on healthcare spending. This spending These costs are increasingly painful for America's families, and in this time of economic turmoil, it's really important to recognize the role of healthcare spending and increased per capita spending on our economic stress in this country. As you may know, the share of household income spent by Americans on medical expenses has crept up gradually. Not the specific amount, but the actual share, the percentage. According to the most recent numbers available on this subject, the average of 13 million families, which is about 11% of American families, spent 10% or more of their family income on out-of-pocket health care expenditures in around the 2001 timeframe, which is up from 8% just a few years before. Many of you probably agree when I say that prevention-based, cost-effective care is essential, and it's really part of the need that we have in the United States to change the way that we think about health care. And I want to reflect for just a few minutes on the changes taking place in Washington and how they relate to this. Yes, significant changes in policy are coming, and senior leadership in Washington in the health area is evolving, but certain critical goals really remain the same, and continuing to improve the health of all Americans is one of them. There are three fundamental problems that are plaguing our healthcare system today, and I'm sure some of you can come up with even more than three. Skyrocketing costs, lack of access, and big disparities and discrepancies in healthcare. Today, approximately 47 million Americans lack healthcare coverage. 47 million Americans. It's projected that the U.S. will spend nearly $2.4 trillion on healthcare this year. That's almost $7,500 per person. Healthcare premiums, insurance premiums, have increased 98%, 98% since just the year 2000, and this increase is nearly 4 times faster than the growth of wages in the same period. Too often, for individuals who lack health care coverage, the quality of the health care that they receive, and anyone in any institution like this is very, very aware of this, is sometimes inadequate. For instance, the U.S. lags behind other industrialized countries in the world in basic health measures such as life expectancy and infant mortality. And every one of us here in this area and all around the country in healthcare should be embarrassed about that. Moreover, we have less same-day access to primary care physicians as our counterparts in other industrialized countries. We've been talking in HHS about changes that are needed in the healthcare system. Today, our providers cannot offer the best care they're capable of, and consumers don't have the ability to consider value when they make their healthcare decisions. Accordingly, we're looking to a future in which consumers are able to find out which hospital in their area has the highest success rate for the procedure they need. And I know, coming from this hospital, the highest success rate is probably right here in these walls. That they can compare doctors not just on what they charge, but also on the quality of the care that they give, and that they can approach health care the way that they approach other major purchases like televisions and automobiles, by comparing it, by looking at an impartial source of information about cost and about quality. Our Secretary of Health designate, Secretary Daschle, has articulated very, very similar themes to these, and I'm pretty confident that we'll be hearing a lot out of this incoming administration. Our healthcare situation illustrates what virtually every stakeholder who is interested in a healthier, fitter nation understands, that we need really profound changes. Americans need to focus more on preventing illness and staying well, and rather than treating diseases. We have to move from a system of medical care that values diagnosing and curing diseases to one that focuses on disease prevention. And that brings me back to DVT and PE. As many of you are aware, DVT and PE affect an estimated 350 to 600,000 Americans each year, and these numbers, of course, are expected to increase as the population ages. Together they contribute to an estimated 100,000 deaths annually. We know that at least 70% of fatal PE detected post-mortem are not suspected or diagnosed. That is very, very high. These are some of the reasons that we put together with Dr. Goldhaber and others the call to action, which is really meant to be a formal starting point, a catalyst for additional work. It's a science-based document, and it's meant to stimulate nationwide action and discussion to solve a major healthcare problem. Dr. Goldhaber, who introduced me a minute ago, and Dr. Thomas Ortel of Duke served as the scientific editors for this call to action, and I'm very, very grateful to the expertise that they poured into the document. We know that in addition to the advocacy that's present and it underlies the work in this call to action, that we have very, very important scientific research underway in this country, including some within these walls. The first multi-center randomized clinical trial of genotype-guided dosing of warfarin therapy, the most commonly used blood thinning treatment, as you all know, is at hand, is underway. Investigators are going to look at whether the use of clinical plus genetic information during the initiation of warfarin can lead to better and safer treatment in patients, especially those with DVT, atrial fibrillation, those who are at risk for stroke or who require warfarin therapy following orthopedic surgery. This and other NIH-sponsored research complements the efforts of 6 already established thrombosis and hemostasis centers that are supported by the Centers for Disease Control and Promotion. I know we'd like to see more research funded by the federal government in this area, but enhancing the research with these investments is going to augment our scientific information about DVT and PE and hopefully result in additional scientific advances over time. But the promises of this medical research, the promises of what we already know about DVT and PE prevention, can't really be fully achieved unless we are also focusing at the same time in this country on health literacy. We can't make improvements in healthcare and in prevention if our messages are not being understood around the country, and we know to a very, very important extent they are not. In 2003, an estimated 77 million American adults, or about 36% of the population, were reported to be at or below basic health literacy levels. When a patient doesn't understand that certain triggering events that you all know, like being hospitalized, confined to bed rest, breaking a leg, or traveling a long time on an airplane, if they don't know that those can increase the risk for DVT and PE, that is a problem. When a patient doesn't know that the risk of these conditions increases with age, especially over age 50, that, in addition, is a problem. When an individual who has an inherited blood clotting disorder or has a family member with one of those disorders, when women who take hormones are not conscious of their increased risk, this is a problem. When users of tobacco or persons who are overweight remain unaware that smoking and obesity are risk factors, we're not going to be able to solve the problem. So increasing health literacy is another one of the priorities that I've been focusing on, talking and traveling around the country. It should be clear that health literacy also includes talking about our own health care professionals in this country being aware of this. And unfortunately, we're not in a position to be able to say that all of our healthcare practitioners are involved. Does every healthcare giver within these walls recognize that these conditions usually represent a chronic illness analogous to coronary artery disease or diabetes? If we're not certain that they do, then improving care of PE and DVT is not going to be as successful as it could be. It's really unsettling to me to realize, as I started doing more work and understanding this problem, that these conditions are still far under-recognized, under-treated, and under-prevented. The good news is that what we do know about how to prevent both of them. Earlier I cited data reflecting this disturbing failure to diagnose PE relative to the large number that are detected post-mortem. And of course, providers should assess our patients for the development of venous thromboembolism and then treat a patient when DVT and PE develops, we know this isn't taking place around the country and in many of our institutions. The problem with such an approach is that VTE diagnosis may be difficult. We know it may be difficult, and that was a lot about what we discussed today. It often goes undetected until it may be too late. I want to talk just a minute about the consensus standard settings system that has gone on in this country around this problem, and how we know from many of these consensus standards that we are not doing enough. The Institute of Medicine in 1999 noted that failure to provide appropriate prophylaxis for DVT and PE is and should be considered a hospital error. So what evidence do we have that points to the type of patients who are at risk when they enter our hospitals? The National Quality Forum, which many of you may know is a consensus quality organization for healthcare, worked on this over a series of years, and they have issued a consensus report that details 30 healthcare practices that should be universally utilized in applicable healthcare settings to reduce the risk of harm to patients, and considerations around DVT and PE are a number of these. I'm not going to go into the details right now, but you may be aware of them. Although this set of safe practices is not intended to capture all activities that go on in hospitals, it's been carefully reviewed and carefully endorsed. And from this NQF consensus report, it's recommended that patients should be evaluated when they're admitted to the hospital and regularly thereafter for the risk of developing DVT and thromboembolism. Furthermore, they recommend that clinically appropriate methods to prophylax, of course, against DVT be employed. Put another way, we have to look at our patients from the second they walk into our institutions for the respective risks and then take prevention steps. And this is consistent with not just these NQF recommendations, but with Joint Commission recommendations. These are the folks that look at the accreditation of healthcare institutions that you're all familiar with. And it recommended, the Joint Commission recommended that institutions develop standardized performance measures for prevention as well as care of DVT and PE, and that they develop organizational policies. And I know this sounds very boring to healthcare practitioners, but organizational policies and procedures, care practices, and appropriate interventions are very, very important in this issue. The policy statement that was issued also focuses on evaluation and performance measurements, such as measuring the percentage of surgery patients that get the recommended prophylaxis ordered, get that feedback back to practitioners, and figuring out how institutions can move to improve those percentages. So individually and together, I think these consensus standards reflect a large amount of agreement about how to prevent DVT and PE. The step that we need to take is getting these implemented in all of the healthcare institutions around the country. You, with the Thrombosis Forum staff and the healthcare experts around this institution, are really better positioned than most because of the history of this institution to make progress in some of these areas. And if you do, the leadership that you show will have an impact all around this country. So as I get to closing here, I want to share really a vision for you, a vision for a future in which DVT and PE are a lot less rampant than they are today. It's a future in which prospective patients whose knowledge of risk factors associated with these conditions is complete as it could possibly be. It's a future where evidence-based practices for screening, diagnosis, treating, and preventing these conditions are clearly understood and routinely applied by all of our healthcare institutions in the United States. It's a not too far off era, hopefully, where discoveries relevant to DVT and PE are regularly and expeditiously integrated into clinical practices. It's a future where efforts of organizations such as patient groups, such as the NATF, researchers, regulators, accreditors, and others are all going in the same way on these conditions. So as the call to action makes clear, we know more than enough to move forward and make more than incremental progress on prevention of these conditions. We can reduce risk if we all work together. Our every single success, our step forward, is going to have the impact of increasing lifespan, increasing quality of life for perhaps thousands of people who we may never know here in the Boston area and around the country. I can scarcely imagine a greater reward for those of us in healthcare. So I hope that you will join me, I know that you will, in doing everything possible to get practice changed, to increase the knowledge of our healthcare practitioners and our patients. I want to thank you for your attention today and give you a few minutes to ask questions now. Thanks.